Okay, so welcome back to our second session of the day. So I'm introducing the session as the chair at this point in time. In a few seconds, I will become the speaker, so bear with me. So this session is about communicating risk. So we'll hear a bit about behavior change, about understanding risk, about managing risk. So we have three lectures to that effect. So we've already heard quite a bit about how we monitor things. We've heard quite a few technological and other solutions. So we're going to start thinking a bit more about the behavioral, if you like, and the perceptual side of things of the next hour or so. So that's me chairing. So I'm not chairing anymore. Now I'm the first speaker of this session. It's interesting. I'm going to chair myself, so I can speak for as long as I like. No, I'm not going to. See, I was expecting that, so she's paying attention. Excellent. Thank you. A huge thank you, of course, to Irene and to everybody at ISOP Israel for the pleasure and the privilege of being here with you today. And as I was preparing this, I had these sort of various thoughts crossing my mind as to what on earth am I going to do with you, because I do deal with patient safety quite a lot, and I have been for the last 15 years. But medication safety is one, but not necessarily the biggest thing that I spend my time on. But I think, thinking about the program and our conversations with the committee, particularly with Irene, what we're going to be talking about is something slightly different to what you've heard so far. And this is about when you think about interventions or programs that you're going to put into place, and we've heard some of those already, how do you do that? How do you get to put something in place that works and stays into place once your attention has shifted elsewhere? How do we implement change in clinical practice, and indeed, how do we make policies work? So this is really what I'm going to talk about over the next sort of 20 minutes or so. You can see I do various things with my time, so you know who's talking to you. I'm a psychologist by training. I'm not clinically trained. I've been working in surgical and cancer care pathways for the last 15 years. I'm interested in multidisciplinary care delivery, which is becoming the norm because of our patients becoming ever more complex. And I think issues around medication safety and managing that within these ever more complex patient populations are becoming quite topical. So what we really want to do with you today is to review some I'm not going to spend very much time with this because you know this already, review some of the core evidence base over the last sort of 15 years in medication safety. And I'll propose to you that there is a shift in that evidence base and see what you think about my interpretation of it. And then we're going to talk a bit about implementation science. So the science of putting interventions that have good clinical evidence base to support them into practice in a way that makes them work. And I'll try and make this practical because, again, that was the brief from Irene. We need to walk away from today thinking about practical solutions. I'll share with you some tools and strategies that we can use to do that, and hopefully we'll have some time to reflect on how much of this material actually makes sense to you. So if you look at the last sort of 20 plus years of looking at the evidence base that we have in healthcare, so forget about medications and drugs for a while, just think of healthcare, what we do in health. These quotes, I think, are quite interesting, and you might have seen them before, but they're fundamentally very worrying because medicine is making huge amounts of progress, particularly in the last generation or two. But how much of this progress is actually translated into routine patient care, day in, day out, when we see patients coming through the doors of our primary care offices, our general practitioner offices, as we call them in England, or in our hospitals or elsewhere. How much of this sees the light of day? And these quotes suggest that we have great medicine, but not all of it reaches the patient. And that's a bit of a problem. So one of the great things that Irene was doing as I was approaching this for the last sort of year or so, she was educating me as to what it is we need to talk about. So she shared this great document with me, which of course I read, so I've done my homework. And in reading the document, I'm picking out a couple of things that I think are of particular interest to this audience. There's a lot in here about education, okay? So you talk a lot about the six part of this document is about staff education, and the 7th section is about patient education. In my mind, when I was reading on this, it was 3 pages long. So there's a lot of activity that's required to educate the patients around drugs, particularly in this case, antithrombotics. Now, this is all great and good. And then, on the back end of this, there's a very nice section in the document, which is what I do for a living, which is how to improve. And the very basic steps are there. Identify where you could do better, prioritize your work, develop an action plan, of course, monitor progress as to whether your action plan is being delivered. But these 4 steps I propose to you are a bit more complex than that when you try and do it. So this is all really good stuff. But the issue is, how do we do this in practice? How do you do that in your clinical service? If you're a pharmacist, how do you do that across a vastly complex organization that is a hospital? If you're a prescribing physician, how do you do that across all your patients in a way that would help you put these things into practice and stick to that? So not just let it slip after 2 months or 3 months. And how do you know, if you're a policymaker or if you're someone like ISOP, that you've got this thing? There's a lot of evidence to support it. What is the uptake like? How does it work in practice? This is the bit that I'm interested in. How these excellent guidelines and tools work in practice. So I went back to basics, as many people would say. So I was trying to educate myself, and I went back to the WHO report about the importance of pharmacovigilance, which is by now almost 20 years on. It's quite old document. If you read about this, I mean, there's quite a few barriers that the report authors articulate in relation to how do you put effective pharmacovigilance into place. And look at number 7. It's just reported, amongst other things, attitudes and perceptions of risk and benefit. And this is what the whole session is about. Attitudes and perceptions are things that exist in our heads, but as a psychologist, I'm really interested in that stuff. They are as real as the rest of the reality, and people behave on the basis of these realities that we've all got in our heads. So this is what is quite important. And this is what I'm looking at in the literature as a shift in that evidence base, where what's in people's heads is becoming increasingly more prominent. So that's a more recent paper by a group that basically looks at barriers to reporting medication errors, not adverse drug reactions, but we're talking about medication errors in hospitals. We do quite a lot of this, and a lot of these reports are voluntary. Some of these reports are mandatory, but some of these are voluntary. What's in green are the facilitators, and what's in red is the barriers. So facilitators obviously help you do that, and the barriers stop you from doing that. So obviously the fact that you want to protect your patients, protect yourself, if you're a provider, and indeed you need to comply with professional standards of practice, every single Royal College, where I am from, or every single professional college or association globally suggests that you should do that. But look at the barriers. The burden on the reporter. We haven't got enough time to do this, people often say. The reporting system is terrible. We can't even find it on the intranet, and the app doesn't work because of the firewall. This is NHS. This is what happens in our country. Information gaps. We don't know what to report. We need to keep educating people as to what makes a good report. Organizational factors is not a priority. A lot of other things take priority over that. And there is a fear and blame culture around reporting errors, because people think that you're pointing the finger either towards a colleague or towards yourself. So a lot of things there to do with how people perceive technically a risk. And the interesting thing is that these are some excellent colleagues who've been doing work on medication errors for many, many years. There's a group of pharmacists from West London, and they've looked at the interaction of these human factors with system factors. So what you've got here is that behavior does not occur in a vacuum. We can talk about behavior from a point of view of a guideline, but we all behave in the context of the organization where we live and work, and in the interactions we have with our colleagues. So there are systems in place to report those things. There are systems in place for prescription. Some of them are electronic, some of them are paper. The same applies to the systems for reporting. And it's interesting that all of this results in, or is the context for the patient interactions that you have, where that's the interface where some of these errors take place and the consequences of these errors manifest themselves. So it's an interesting sort of discussion that we're talking about human factors now and how these interact with system factors. So we've heard a lot, and you will keep hearing quite a lot at this meeting, about what comes from the top. because we do have national and transnational, so global organizations. We do have regulation as absolutely critically important, and we do have reporting systems and standards. But what I'm proposing to you is that we also need to start thinking what happens from the bottom. So what happens at the front line? How do we encourage reporting, effective reporting behaviors and practices, but also change? Okay, we reported stuff. How are we going to put in place the intervention that will now solve or reduce the problem that we have? We understand that, I would propose to you, in the context of pharmacovigilance and medication safety, a bit less well. So we can do a bit more than that. And the reason I'm proposing all of this is because in healthcare in general, we tend to be a bit slow in taking up change and innovation. This is a study that was done a number of years ago now, and they've estimated how long it takes for something that's well evidenced through trials and meta-analysis and guidelines to be translated into routine patient care. Routine means that every patient who's eligible will receive whatever the intervention supported by the trial. Okay? And what we find is that it takes half a generation. 17 years is too long. How many of you have a mobile phone that is 17 years old? Yeah, of course not. How many of you drive a car that is 17 years old, unless you like antiques? You know, we don't do these things, and yet, when it comes to healthcare, we're a bit out of date. Now, obviously, this is a difficult number to estimate. Sometimes we're very quick, and sometimes we're a bit slow. But think about the fact that healthcare, historically, has been slow to take in some innovation. So what happened about 15 years ago? There was a bunch of guys that got together and said, look, we need to throw some science at the problem. We throw clinical science, and we've created evidence-based medicine to answer clinical questions. Now, we need to develop a different kind of science to try and understand how a well-evidenced intervention needs to be applied to solve the problems that we're talking about. So that was the birth of implementation science, and we've had a journal. There's a journal that's called that. That's the only journal so far, but we're going to have probably another 3 journals coming out in the next 6 to 12 months because the field is growing. Implementation science, something really simple, is the scientific study of methodologies that promote uptake of research into routine healthcare at the front line, at organizational level, so evidence-based pathways, or at policymaking. There's the science that doesn't just create clinical effectiveness evidence, but it tells you something about how you take that and put it into place at scale. So you do things nationally or you do things globally when you know they work. And there's an interesting WHO report that I'll show you what that is on the next slide, that offers a complementary definition that defines implementation science as a study of processes used of implementation of initiatives, as well as the contextual factors that impact on those. This is exactly what we're talking about here. What is the context within which you put reporting systems in place? What is the context in which you put electronic or other interventions in place? Where is the context in which you put self-report assessments, like the one I showed you earlier in place, the ISMP assessment? How does that context impact on the uptake and the use of these initiatives? I know that for many people, implementation science might be something rather novel, but from when the journal was introduced in 2005 and then started publishing in 2006, we've got a huge, if you look at the red line, this is the rate of submissions. Now, at this point, we're hitting about 1,000 plus a year. The science is expanding. The funders are interested. There's now research funders, particularly in North America and Europe, that fund implementation research, not clinical effectiveness. We don't need, for some interventions, any more clinical effectiveness research. A waste of money. We need implementation research to figure out how we're going to put these things into place. And this is what's happening. So this is a WHO report that I talked to you about. Really nice, gives a really nice overview of what implementation science is. You can apply it to simple things. So they've got really great examples of how mosquito nets for the prevention of malaria have been implemented in a number of sub-Saharan African countries. You can apply implementation concepts to pretty much anything. It doesn't have to be complex. So the interesting thing, if you look at the highlighted part in blue, implementation research is not about the safety of a drug. It's not about the early invention. It's about late application at scale. We're interested in things that work, but how do we make them work for entire populations? So we achieve what a research study had shown for as many patients and service users as possible. So if you think about research translation, implementation research happens at the right-hand side of that translational pathway. So this is the basic premise of the entire science. If you remember anything from this lecture, just remember this. So if you're going to put an intervention into place, be that a sort of antithrombotic, that sort of self-report intervention or whatever else it is, there's two things that you need to think about. The effectiveness of your implementation, so how well this will be taken up and used, is a function of at least two things. First of all, the clinical effectiveness of what it is you're putting in. So is it supported by evidence? So we don't want to be unevidenced. So do you have a good story to tell that whatever you're implementing is actually clinically effective? And what we call implementation factors, which of course we can measure. And I'll show you in a moment how we can do that. So what are those implementation factors? Because we understand clinical effectiveness, right? This is what trials do. What are those implementation factors? So this is based on systematic review and expert consensus, and this is the current gold standard for evaluating an implementation of a program or of an intervention. So you've got to look at all of those things, ideally. Most cases we can't because too much to do. But ideally, we have to look at all of those, and we've got to measure and optimize them so that our programs have a chance of working within our hospitals or within our healthcare systems. So we need to make sure that our interventions are acceptable. This is a perception, right? This is what I was talking to you about earlier. These are all human perceptions, but they matter in terms of how we all behave. We need to make sure they're acceptable. We need to make sure they're appropriate. I'm just jumping one for a reason. People see them as appropriate for them, because often people go, oh, great stuff. This is really a nice intervention. But that's not for me, though. Why? Because I don't make errors. I'm good. This is for my colleagues who are a bit more careless. We've seen things like that time and again. Or this is not for my patients, because my patients are very different from the patients that this was trialed on. And that might have a reason to it, but we've got to explore it. Feasibility, people might love your intervention, might love your program, but they're completely unable to do it. Haven't got enough staff, haven't got enough training, haven't got enough experience, or they've got all sorts of other problems. If something is acceptable, appropriate, and feasible, people will have an intention to adopt it. They develop that in the back of their heads, and they then, unless they have that, there's no way it's going to happen. They'll tell you it happens, but it's not going to happen in reality. Fidelity is absolutely important. We used to talk about high fidelity systems, sound systems, right? People say, oh, this is my hi-fi, what's your hi-fi like? The same applies to clinical interventions. When you put something in place, you put in a self-report checklist, but people might just tick the boxes without really thinking. So the fidelity there is low. They're telling you they're doing it, but in reality, they're not really using the intervention. Checklists, and we've heard earlier about double checks. Classic example where you can tick the box that you've done it, but your mind is elsewhere, so you're not really using the intervention. So fidelity is applying the intervention the way it was intended or designed. The cost of implementation, absolutely critical. We need to know that. That's not the cost effectiveness of the clinical trial. This is the cost of implementation. So if you need to train people every 6 months as to how you're going to use the self-assessment report, well, you've got to factor in the fact you take them out of service for 3 hours. Someone's got to be there to teach them. That might incur some costs. We've got some beautiful catering today. Someone's going to have to pay for that. We've got to think for these simple things, because this is what my service managers are asking me every time I go, have you seen this latest trial? Great stuff. How much is it going to cost to put it into place? Coverage. Are all the patients going to get it, of those who are eligible? So that's a really nice objective measure, so we need to collect that. And of course, sustainability. If you change your attention to something else, or if you change jobs, will people still use that program? Will they still use that intervention? If they stop, then it's not sustainable. Was it worth doing in the first place? So let's go into some practical stuff. People say, right, oh, great. How are we going to measure all this? Here's how you're going to measure it. These are validated scales published about 1.5 years ago. If you want, you can do this at scale. You can survey everybody in your organization or whichever environment you want to assess. If you want to know if something is acceptable, what you've got in brackets here is a gap. You put whatever you like, whatever your intervention is. So the self-assessment report for the antithrombotics, you just put that in there. And then you run it through. These are 1 to 5 Likert scales. You score it, you sum it up, and then you've got a sense of whether something is acceptable, something is appropriate. So this self-report seems fitting, suitable, applicable, and like a good match. This is what this was developed by a group of in northwest United States. So, you know, the wording you've got to use, but the intervention is entirely for you to fill in. And is it something that's feasible? So this gives you an instrument to assess those things. The other thing that the science has been doing for the last 15 years is developing some sort of theoretical frameworks to try and understand why things work and why things fail to work. Because a theory is a useful thing, you see. So if you have a theory, then you have hypotheses as to what it is that's driving an intervention, and in your hospital it works really well, and in my hospital it failed miserably. Why? So here's a theory that seems to be doing quite a good job. It's been around for a number of years and it's got quite good evidence to support it. It's called the Consolidated Framework for Implementation Research. And basically, it tells you when you put an intervention in place, there's 5 things you need to look at to determine whether it's going to succeed or fail. You've got to look at the characteristics of the intervention. How complex is it? How much evidence does it have behind it? Who's going to deliver it? Then you've got to think about the context of your own organization, your service, sometimes the micro context of your particular pharmacy service in your hospital, or if you're running a ministry, that is the context of your national policy making. So you've got to look into this. Your outer context is usually country-wide or region-wide or global. You know, if the WHO issues guidance, I mean, people notice. So that's the wider context in which your intervention will go and fall into. Who is going to be involved? Number 4, who are the people? Are these the pharmacists, the providers, the trainees, the patients, all of them? Who are the stakeholders? And who's going to be delivering what in terms of your intervention? And finally, what is the process? Are you going to train everybody? Here's where training comes in. Training is great, but what else are you going to do? Are you going to do a communication campaign around this, an awareness campaign? Are you going to have posters? Or are you going to have an email campaign? No, you're not going to have an email campaign because the first thing people do when you go to the office in the morning, you see something that's a circular, comes from the organization, you click delete. So an email campaign is not going to work. So you might want to do something different. I'm just coming up with sort of examples that we've used before. And again, having a theory is practical because the guys who developed the theory, and all of this is free on the website of the Consolidated Framework, they've developed a set of validated questions that you can ask. So you can use them as a survey question. More usually, people use them as an interview protocol. So if you want to know about the characteristics of the intervention, then there's a number of questions you can ask. These are just a sample. There's tons and tons of questions you can pick and choose. So someone has thought the questions for you. You just go and select them, and you can put them in place when you do your evaluation of how your implementation will work. How are you going to assess the wider setting, the wider context, the context of your organization? See, for example, how would you describe the culture of your organization? This is the sort of thing that you've got to think about. Someone says to you, nothing ever changes here. All we care about is reducing costs. Well, that's a difficult culture to work with. So you've got to start working with those barriers. The people and the process of implementation. So look at this question. Can you describe the plan for implementing, say, our self-reported assessment? If people cannot tell you what the plan is, this means that they don't understand it. It's not clear. It might have been communicated well, but it hasn't reached out to all of them. So you've got to address this because that's hints at a barrier. So this is something that, again, you can do very practically to figure out how an implementation is going. The one thing that people get quite worried about is this slide, when I put it up. We talk about change within a hospital organization, within our healthcare service. I remember a case a couple of years ago when one of the hospitals I work with came to me and said, we're going to be changing all our major acute care pathways, and we're going to change one pathway between 2 hospitals, which are about 5-6 kilometers apart, to both of those big, large organizations. And we're going to do this every 6 weeks for each pathway. And I was in shock. I was like, who told you that? And they had some management consultants who told them that. And I said, that's wrong. It's not going to work. You know what? 2 years later, it hasn't worked. You can't change the way an acute service works in 6 weeks. Why? Because a successful implementation takes anything between 2 and 4 years. And the stages in these implementation, they're not just linear. You need to explore, install, which is your initial sort of piloting, and get the resources in place and prepare the organization and get the readiness up so everybody's signed up to the initial implementation, which might need revision, to then go on to full implementation. And if you look at the arrows, they don't just go to the right, they go in both directions. So you're going to get setbacks. You've heard this in implicit format from Irene this morning. Even this meeting has gone through this process, because I remember discussing it early on in 2015 or 2016. It was in Prague. Excellent meeting that was. But it takes a while to get things into place, and people have to live with the amount of effort that we need to put in there. So you've got to stick to it, not just jump around to different things. And we're finishing off here. How are you going to get all of this to work? What strategies do we have to achieve behavior change and organizational change? Well, we've got loads, but we're lucky because there's a bunch of people who, again, did a systematic review of all of healthcare, and then they did an expert consensus. And they said, what are the change management strategies that work in healthcare, and what are they? So they've managed to list 73 different documents. If you get this paper, which is all open access, you've got a shopping list of 73 things you could be doing to achieve change. Now, 73 is very long. I would have to have 73 slides here, but I'm sparing you that a pain. So people have grouped them in 9 categories. So what you do audit and feedback. And this is something that most people don't even realize, the implementation strategy. So plan, do, study, act falls under the same category. So you evaluate and you iterate. So you do trial and error. This is what that is. You offer assistance. Often we throw programs at people and we hope that they're going to use them. But without help, why would they? How could they? So you offer supervision, you offer facilitation, you put together project team meetings, and you help them take a program off the ground. Adaptation and tailoring, we allow people to adapt because not every hospital is the same as every other hospital. Our patients are different, our volumes are different, the needs may be different. So adaptation is fine, but it shouldn't be random. We should document it and test it to make sure it works. Obviously engaging with stakeholders, establishing champions, might be senior clinicians, it might be vocal clinicians, it might be vocal patients. That is important. Training and education, I'm not going to say very much because most of you will be doing this anyway. Support to providers. So people are saying, great, I want to do this, but I have no time. I work 12 hours a day as it is. So you say, okay, fine. So we're going to negotiate with the management to create a day a week where you do change management and you're leading on the antithrombotics program. That's in your contract now. You're accountable for it. That's an implementation strategy because then people can take it up and do it. We don't expect people to do things in evenings and weekends, you see. Well, we normally do. Patient and service user engagement, patient advocacy is really important, and I think we should absolutely keep them at the center of our attention. Financial strategies, when we can use them, incentives or disincentives, and indeed changing the infrastructure. So creating accreditation schemes or creating partnerships where people would have a keen interest of taking part and contributing. So there's a number of things, and again, I refer you back to this paper. So does it matter if we use those strategies? So we haven't got any evidence for them. Some evidence is emerging, and the answer is yes, it does matter. This is a really simple study. People were given those 73 strategies. That was across all the Veterans Affairs systems, hospitals in the US who treat veterans for hepatitis C. And they said, right, okay, we need to check out whether, and we know that treatment is effective and curative provided that they get started on the treatment. And they did a simple correlational analysis of how many of those 73 strategies those centers are using, how many veterans did they manage to get started on treatment. And they found a reasonable correlation of 0.43, which is quite nice and chunky. But look at the variation. On average, people use 25 different strategies in each one of the centers. And obviously, the more strategies you use, the more likely you are to succeed. Why? Because there's no one barrier. The barriers are multifaceted. So the more strategies you use, the more of the barriers that we talked about you're actually addressing. So there's a good message there. So there is a body of implementation research there available for you. I'm just scratching the surface and I'm giving you the tip of an iceberg. Some really nice implementation papers coming out in the last few years in the literature around particularly medication errors and what we do about them. And the question I have for you, this is perhaps for some of you a new language to organize your thinking and your intervention design and evaluation. Is this useful? Can you use some of those tools to improve the way interventions are taken up? So thank you very much for the space and the time. If you fancy talking more about implementation, spend next month with us. We've got 3 days dedicated to implementation. In fact, we've now launched a national conference in the UK to talk just about implementation approaches. So would welcome you there if you're interested. Thanks for the opportunity to be with you, and we might have time for questions.